This is a trial that's just being modified, and it's basically an oligomet trial. I don't know these slides, but you guys all know about oligometastasis. There's evidence that surgery alone for a single brain met, both surgery in the brain as well as in the lung, can lead to long-term cures. So it's a different subset than polymetastatic disease, and there's basically, it's been shown in, looks like in staging, it's in modified staging, that's a whole different subset. So the question is how to treat those and whether local consolidation can really improve things over no local consolidation or just systemic therapy alone. I'm going to kind of flip through these slides. She got a lot of slides here. So what this trial is going to do, this may be the old one. You guys are okay if I flip through these slides? Oop. Well, let me just get to the bottom line. So basically, we ran a trial at MD Anderson where we randomized patients to either systemic therapy followed by maintenance chemotherapy, which is standard for metastatic disease, and it was 3 metastatic sites, not just one metastatic site. The other arm was chemotherapy for 3 cycles. If you did not progress, then you were able to be randomized, and then you got local consolidation, either surgery or radiation, and then got maintenance. And that trial was shut down early because of a marked improvement in progression-free survival. Now, one might think that that would naturally happen if you're going to cut out the primary tumor, right? You're going to get progression if you didn't do that. But what was interesting in the trial was there also was a decreased time to new metastases, which was unexpected. In fact, we had set the trial up because we were worried that metastases may occur quicker if we take out the primary. And this is based on some Judith Folkman data in the laboratory where he had a single mouse where he would resect the primary and the metastasis would go wild. But we set that trial specifically to make sure we weren't worsening things, and in reality, progression-free survival was markedly improved and had to be stopped, and additionally, time to new metastases was lengthened. So it really looked like local consolidation was a reasonable strategy. Surgery was a big part of that. About 1/3 of the local consolidation was done with surgery, and we would tend to do, like if it was a lobectomy, we would do that. If it was a pneumonectomy, we wouldn't. But we worked very much in a multidisciplinary fashion. Well, anyway, simultaneously, NRG took that same concept, and Jessica was with the group, but I guess they didn't consult her very well. But they ran it all the way through Thoracic Malignancy Steering Committee, and suddenly it was a trial nationally, except surgery was completely excluded. And I don't know if what your experience is, but my experience is I've seen a lot of in the community, people will just do stereotactic on absolutely every single met. You can have 6 or 7, they just do it. So I think it's a question that really needs to be answered, and I think surgery plays a role in it. But anyway, this trial was an exact copy of the previous one, and there were 2 things that could have been better. One is, in this day and age, does immunotherapy help in oligometastatic disease? And 2, does surgery still play a role, clearing the primary and so forth? And so Jessica worked really hard on getting this to be modified. It had to go all the way up so that surgery could be included, as well as a modification to allow immunotherapy. So it has now been modified so that it's patients with metastatic disease. I think 3 or less sites will get randomized to either chemotherapy plus immunotherapy versus chemotherapy plus immunotherapy and/or immunotherapy, I think, followed by local consolidation. And surgery is a part of that. So we should try to participate in this because even though it was worked really hard to include surgery, if we don't put patients on the trial, they'll all just be radiation-only patients and there won't be any data. And there's one other oligomet trial that's going on in Europe, and that doesn't include surgery either, it's just SBRT. So I think as a group, if we can help support this NRG trial, at least surgery is still on the map for oligometastatic disease.
Steve, how are you going to decide who gets SBRT or surgery?
Yeah, so that's a big question. So the way we tried to do it was to say, at Anderson, we kind of just talked amongst each other. But in this situation, what it says is, if the primary can be resected with a lobectomy, then it is preferred to do surgery. If it requires a pneumonectomy, then it's preferred to do radiation. And additionally, one of the Mets is encouraged to have at least one site to have radiation just because of the potential abscopal effect. But you're right, that's going to be difficult. It's going to be a little heterogeneous, but.
And your previous study where you...
And that was one of the reasons that they didn't want to include surgery, not just because they don't like surgeons, so I don't want to be a conspiracy theory, but the other was they wanted to say this arm is completely homogeneous, everybody's going to get just stereotactic. We argued, we had done this other study, there were no mortalities when surgery was utilized, so we were able to convince them to include surgery, but you're right, it's a little more heterogeneous.
And your previous study that you did at Anderson, where you had both surgery and SBRT, did you see a difference in terms of progression between the two?
It's very small numbers because the trial was stopped early, and so I went back and subset analyzed it, and there wasn't any difference. But maybe with longer term there will be some, But there wasn't an advantage to doing just radiation. And I think that's kind of the presumption these days almost, is like it's just assumed radiation enhances immunotherapy. And I think that's still a question, the abscopal effect, because radiation can both upregulate and downregulate the immune system. There's some data that you can upregulate Tregs, T suppressors, and all kinds of things.
I just have more of a comment. I feel like I hear people murmuring about, what are we going to do as thoracic surgeons because stage 1 is going to SBRT and we're not going to have any cases left to operate on. I think this is what we're going to be operating on. So we're going to have these stage 4 patients that are living longer than we've ever seen before with the new therapies that are out there, and we should be part of the mix, and I think we have a lot to offer to these patients that have what used to be inoperable, advanced, short lifespan disease, and now they're going to be around for a while, and we need to be part of it.
Yeah, I agree completely with you, Linda. I think one of the challenges we've had to show that surgery has a role has been that when you're looking at stage 3 or even oligometastatic disease, so many patients fail from systemic disease that it doesn't matter if your local control is a little bit better with surgery, right? But we may be in a new era now that the systemic therapies or the targeted therapies are able to control the distant disease longer, so it's going to make more difference if the local control is better. So I agree completely with you. Please enroll on this trial.
Steve, could you just give us a flavor of what you were actually operating on in the study? There must have been some tendency towards some body cavities or body parts that were more likely to get SBRT, but just beyond the primary being surgically resected, was there any generalities you can impart to us?
Well, so first of all, the trial was really set up to try to screen out patients that were going to progress. Because when you're dealing with 3 oligometastatic sites, and N2 disease was considered a 1, so if you had an N2, that was 1, and if you had 2 other sites then. And so the most important part was, the chemotherapy that was given up front, and about, 30% of people were washed out because they progressed while on chemo. So the people that weren't washed out were people who looked like they'd had a response or hadn't progressed and potentially would benefit from local control with surgery and/or radiation. And so then we would present them in a multidisciplinary conference, and if it looked like surgery could be done safely, then we tended to do that with a single extra thoracic met being radiated. So we tended to favor trying to do surgery if it could be done safely. I do remember one case that I did where, you know, we took out the lower lobe, cut through the diaphragm, and then took out the splenic met, but I'm not sure that's something that I would recommend. Everything went well. Everything went well with the case. We got a bunch of, you know, we got a bunch of T cells in that one, I'm sure. But you know, our radiation therapists worked with us, and we tended to try to favor it. We got tissue that way and stuff. There was some questions that way. But I think surgery does have a role in this disease, you know, because it does have better local control, especially with some of those centrally located tumors that have a lot of lymph nodes. I really still think surgery plays a role in local regional control in that arena. And then, like Linda said, I think if they can control the systemic stuff more, there's still going to be a role for surgery.
So I was at, this is a side topic, but I was at the esophagogastric NCI steering committee meeting just before Christmas, and the idea also came up of doing this in esophageal cancer. Do you want to comment on that one?
Maybe I'll let Wayne comment. My experiences with oligomets in esophageal are extremely rare compared to lung, and they have not been super favorable. Like I just accidentally had a guy we did an esophagectomy on who had a lesion in the lung. They did a biopsy on it. It looked like it was a lung primary. Went in, did a pretty tough operation, a sleeve, and took some lymph nodes, and it ended up being an esophageal met, and also in the lymph nodes. Okay, I said, oh, okay, well, this is probably good. It's like an oligomet. I'll take care of it. 2 months later, he came to my clinic with swelling in the left arm, and he had a nodule, and it's biopsy positive for an esophageal met. So
okay, don't go too far on that, because you know the anecdotal evidence is. So you also have a patient who's 7 years out that presented with metastatic disease, who was HER2 positive and was operated on, and then has had multiple mets, and you know has done very well. So you know the endpoint for the oligomet.
You're such a good partner. Thank you for remembering
well,
that.
It was your patient. And we took out some lymph nodes in his neck after you had taken out his esophagus, and I had looked at him for an EMR at one point. So, you know, the endpoint for the oligo lung trial was looking at PFS, and so I'm not sure that we're absolutely looking to cure patients, but we're looking to prolong their life and seeing how we're doing that through local regional therapy. So we did put together an oligometastatic trial for esophageal cancer with kind of the same premise as looking at 3 different sites. It's now open at MD Anderson. We are including some groups ad hoc. It's not being offered through a cooperative group yet, but we'll see. It's the preliminary shot over the bow. So right now we're looking at opening it up in Toronto and McGill, and also at MD Anderson. So we haven't accrued yet. I do agree that there is a subset of patients with oligometastatic disease and esophageal cancer that does well, and this is out of an observation that patients were going off to the medical oncologist, being treated with systemic therapy for upwards of 6 months or a year. All the metastatic disease was going away, and then the patients were recurring at their primary or at a single lymph node spot in their neck, and then what would it take to go after those areas? So, you know, same as with lung cancer, there's probably a unique subset of patients that have slowly growing tumor, and can we affect the overall state of the disease by operating? And I think the answer is yes, but we have to figure out what that category is, that subset of patients.
Yeah, I think it's a really interesting idea, which is part of the reason I asked. Any other comments from anyone in the audience on it? Do you want to say a word about the LCMC then?
Yeah, so there's also another kind of exciting trial that's coming forward that surgeons actually can be a part of. So anybody who's interested, please let me know. So it's called LCMC4, which is basically looking at patients who have like mutations, and not just EGFR and ALK, but also these really weird ones like TRK, RET, a variety of different ones. And what it's going to do, it's going to be a basket trial. So it's then a neoadjuvant study with surgery at the backside. So if you happen to have, let's say, an ALK mutation, of course, you'll get osimertinib or crizotinib or one of those two, and then you'll get surgery. And the idea here is, it's actually a basket trials because not very many of these patients exists for one institution to do only one of them, but there's numerous arms in there. So any one of these arms that a surgeon was interested in, was specifically designed for that, you can kind of write that arm of it and then be a part of this whole trial. So it's a real opportunity because they're trying to figure out how can we get surgeons more involved in neoadjuvant trials. And so this is an opportunity for that. I think the really interesting piece on this is that, when you resect the patients who have gotten a targeted therapy, those who still have residual disease, you'll be able to do a lot of studies on that and why were they resistant to the targeted treatment. So that's a really interesting question, whereas if you resect them and most of it has been killed, then that's not quite as interesting. It might be good for the patient, but this will be a very interesting question that surgeons can be a part of. So anybody who's interested, feel free to give me an email. They're going to try to get a group together to kind of write each one of these individual kind of protocols, and then it'll be a basket trial. And the advantage to the patient is that you'll get the drug for free. And the challenge is going to be how do you get the diagnosis, the genomic diagnosis in a timely fashion without an early stage patient, because it's 1B to 3A, being nervous and wanting to go immediately to surgery. So that's the part that they're really working on. Part of it may be doing a blood biomarker study with Guardant. So that can turn around pretty quick, 7 days or so. They're trying to see if Guardant will get on board to pay for that. But this is a trial where surgeons can get on the ground level, and I think there's a real resurgence in interest in neoadjuvant. So anybody who's interested,